good afternoon. So I'm Purnima and I welcome you all for the Green Oak Expert Talks. For people who don't know about Green Oak, so Green Oak is a community mental health setup founded by Dr. Soumya Krishna and Dr. Ashlesha Bagadia. And it has been around since 2019. And now we are privileged to have a team of almost 14, 15 people, which includes psychiatrists, clinical psychologists, and counselors. Um, uh, s- so we actually we see young adults and adult population in terms of psychiatry and psychotherapy, and we run specialized services like perinatal services led by Dr. Ashlesha Bagadia and a low-fee clinic called Samartha. Um, and this is expert talk that we run every month. And this month we are going to talk on perinatal loss. And I welcome Dr. Geetha Desai, who is our expert for this month. She is a professor at NIMHANS and has been associated with the Perinatal Psychiatry Services since 2007. She is one of the leads in curating and executing perinatal certificate course, which runs on an annual basis. And for more information, you can contact her. And yes, so over to you, Dr. Geetha. So before we begin, I'll just give some ground rules. So initial first 30, 40 minutes, it will be the presentation by Dr. Geetha. In want to ask yourself, you can switch on your video and use the raise button, click on the reaction box on your menu bar, and I will help you facilitate it. We have received certain questions beforehand, and if that is not covered during our presentation, I will be taking it up. In terms of any queries or something, you can always put it in the chat box, and either me or Devanshi will be able to facilitate it. Thank you, and over to you, Dr. Geetha.
Thank you, Purnima and Devanshi. Okay, so shall I start share screen?
Yes.
Am I audible? Okay, so thank you, Devanshi, for initiating this topic because I have been working in perinatal psychiatry services for a very long time, and this is one area we don't discuss much, and we're quite unfortunate that we don't talk about it, and we actually continue the invisible loss tag attached to perinatal grief. We just continue to do the same. So let me kind of take you through what we are going to talk about today. So I think let's first understand what is perinatal loss, because there are lots of confusions about what constitutes perinatal loss and what are the mental health consequences of perinatal loss, and what is perinatal grief. Is it different from any other grief? And how do we assess perinatal grief, and what are the interventions that are there for perinatal grief? Now, we know that, there are so many terms that we use for perinatal period. The definitions of perinatal period start from conception to immediately 6 weeks after childbirth, and then sometimes it is taken as 1 year. So even the definition of perinatal period is kind of varied for the onset of mental health conditions also, as well as other, the obstetricians have their different definitions. So when we talk about perinatal loss, it actually encompasses, from loss that happens post-conception to 1 month after birth. Now, of course, we can argue about it that, how does one define this loss? Is the loss different when the loss happens within the first 3 months, or the 6 months, or 9 months, or immediately after the birth? So, but I think in a way, it is a very important description, because often miscarriage, or what we call termination of pregnancy, is considered as not a loss, a bereavement, but rather it would go in terms of termination, and it's a very medicalized kind of a thing. But probably neonatal death, people still give consider it as a loss and bereavement and stillbirth also. So I think in that way, what the current standard definition is, any loss that happens from the time of conception to the period 28 days, that is the new, or 1 month after childbirth. So is it, I mean, are there different, I mean, like, I'll also address the terminologies. Neonatal death is something that happens within 28 days after the birth, and stillbirths, there are some differences. Some say 28 weeks onwards to 50 or 500 grams weight, or 24 weeks to onwards, and anything before 20 weeks is considered as miscarriage. So there's lots of nuances. I mean, unless you're a researcher where you want to kind of study this phenomenon, but it's very important to understand that these definitions help us in some ways to see, like if you understand why we are discussing perinatal loss, is because there is a relationship between the mother and the fetus. So when does it form? I mean, all these questions come up, does the mother have attachment to the fetus in the first 3 months, when, differentiation would not have happened. So that is the reason why I'm spending a little more time on what is perinatal loss. And again, one of the things that I haven't mentioned here is loss due to pregnancy loss due to fetal anomalies, or pregnancy termination due to fetal anomalies. Now, that can happen at various points of time. Different. We know about many cases in the legal system where they've discussed about termination due to significant fetal anomalies. So that also is even though it is an elective termination, but it is still a loss. So there's a lot of debate about when somebody makes a decision to terminate, should it be considered as a loss? But the point is, I think it is a loss. It is, I think, irrespective of whether it is elective or spontaneous or whatever, it should be considered as a loss. It's very important as health professionals for us to be clear on this, and not be okay, I'll come to about that, because many of the grief reactions and the distress is caused in the medical system, or when they go for counseling. Some of the secondary trauma actually happens there when, like, for example, somebody who has made a decision to terminate the pregnancy and then develops distress should also kind of be seen in the way anyone who has had a spontaneous. That's the thing. So sometimes I think these definitions also help us to kind of think why we need to, understand these definitions. And okay, so this is about perinatal loss. So coming to now we have established that there is a loss because there's a loss of an entity. So what are the consequences of when a mom loses a fetus at whatever stage? So there can be a normal grief reaction, like how we have grief as a normal, natural reaction to any loss. So the mother can go through, the first and foremost is, let's also normalize some of these reactions that happen. It's very important to sometimes even address this as, okay, this is a normal reaction. Because I'll tell you that people, sometimes mothers and fathers, are not allowed to grieve, because it's like, it's, and like I said, it can be, it's like considered as an invisible loss. So first and foremost, even though I won't say it as mental health consequence, but I think they can go through the normal grief reaction. We all know, I think that's everybody's favorite question and answer would be, what are the stages of grief? But I think we need to understand that grief reactions can be very varied, and the stages we have enough data to say that not everybody goes through all the 5 stages, and there can be different ways of grieving. Uh, they can develop anxiety, more so anxiety in the subsequent pregnancy. So let's say if somebody has had a perinatal loss, so and they plan pregnancy, or they're pregnant for the second time, or subsequently they can develop anxiety related to perinatal loss itself. Or not everything has to be grief, but this can be anxiety about recurrent loss. Also anxiety related to about forming an attachment with the baby, and anxiety related to their own safety and the safety of the baby. The reason why I'm bringing up these concepts or explanations is these are not typical generalized anxiety disorders or panic disorders, phobias, but they can have different manifestations. So the anxiety may be very specific to the pregnancy, safety of the baby, or other, kind of support. Then they can go through a depression. I will come to the risk factors. Who are those women who can actually develop a proper depressive episode? And post-traumatic stress disorder. Even though in our country, the stillbirth rates and neonatal death rates are quite high, but the study on PTSD related to childbirth and perinatal loss is very, very minimal. But of course, there's enough literature to suggest that PTSD is quite prominent after traumatic loss. And we also need to understand that sometimes these are sudden losses. Like it doesn't, where I'll talk to you about it. How do we, how is perinatal grief is different. So there's nothing like, and you anticipate something will go wrong. So the suddenness of it, and the kind of care that was provided, and the kind of support of whatever, how the others reacted to this loss, all these could have an element of trauma attached to them, and women can develop PTSD. Like I discussed about normal grief reaction, there's something called complicated grief reaction. So generally grief resolves over a period of time, but in complicated grief, the grief may last longer period of time and get, the functionality may be impaired due to grief. So there are others problems that can happen, which may not, like sleep problems, eating problems. So some of these other difficulties are also quite common as a mental health consequence of perinatal loss. So coming to the phases of grief, I know you all were expecting a 5 stage, but I have just kind of used a different, especially for pregnancy loss, is avoidance or protest. I think, like I was mentioning, it's a very sudden loss. So there's a lot of anger, disbelief, shock, and a sort of numb feeling, denial. All this kind of is the first phase of grief. Then there is the confrontation and disorganization. So this is basically coming into reality that this has happened, and you have to face the reality of the loss. So probably the second phase is the most difficult phase for the parents. I am using parents because it can, even fathers experience some of these grief phases as well. The third phase is accommodation and reorganization. That is about, yes, the grief, the losses happened. I have, emotionally affected by it, but the woman and the parents can actually kind of, go ahead and plan their activities, and the life comes back to not what it was earlier, but at least some functionality will return to, and then they can plan subsequent. So what is like I was mentioning, what are the things that constitute grief? One is there are a whole lot of emotions, I think, have to be addressed. So there can be anxiety, there can be sadness, anger, uh, frustration. So, and this is more related to the what I was talking about, avoidance and protest. So the anger is not only towards anger towards themselves, anger towards the healthcare staff. We know that many a times violence against health professionals is when there is a loss, isn't it? So there's a lot of anger that is directed towards the healthcare professionals, because there's a sense of belief that the baby was kept in the neonatal ICU, and then there was some sort of hope, and then there is then they break the bad news. Behavioral and cognitive symptoms in the form of intrusive thoughts, avoidance of the cues related to the baby, isolation, guilt, and self-blame. These are some of the symptoms. This is what I'm talking to you is a normal grief reaction. It can last for about a year and may extend up to 2 years. So these are feelings of guilt and self-blame. Like, I think perinatal loss also kind of, affects the identity of the woman who was expecting to be a mother, become a parent, and then that identity has also been taken away with this perinatal loss. There's a whole lot of future associated with having a baby. So that also is being taken away with the parent and the child envy. So we all know, I mean, when you talk to mothers who have lost babies, when they see other mothers, interacting with babies, or so there could be a child envy, that you don't have it and others have it. So these are some of the phenomena that, and mind you, that not everything is pathological here. I think we need to probably, because we don't talk about it, not everything, and there can be a tinge of envy sometimes when they see, other mothers feeding the baby or anything, but it's okay. What they do with those feelings is something that we need to address. But when somebody is having these feelings, it's important to kind of address them. So before we go to risks for developing complicated grief, how different is perinatal grief? Like, for example, if you look at grief in other situations. So there is a recognition that this is grief. In perinatal loss, grief, there is no recognition because there is no relationship formed. There is no concrete identity that is given to the baby, because culturally there are many different things. You don't name the baby before the baby is born, and you may not know the gender of the baby. You may not know how the baby looks, but you might have some ideas about how the baby might look. So one is the recognition. The second thing is about, like I said, there are no concrete evidence that, or I would say even if the baby is born, then it's, slightly, at least the mother might have seen the baby. But before that, that might not even be a possibility. So there is no identity given to the fetal loss or stillbirth. The third thing is, I think when we talk about grief resolution, we say that, reliving and then, realigning with life. You're making meaning and then move on. Or reinvesting in other relationships. So let's say there is a breakup and then they reinvest in another. But reinvesting in another relationship is the most difficult thing, especially in perinatal loss. So in that way, I think a perinatal grief and loss grief is different, because the identity is not there. You can't hold on to any objects that you thought could be with for the baby. Third is even, moving on with other relationships. It's still possible, but in this, it's, future is kind of linked to having a baby. So that itself is being taken away. So in this way, I think perinatal grief probably has its, kind of needs discussion at a separate, as a separate level. So if it is a normal reaction, we know that, not everyone, or all of us go through grief at some point of time in our lives. And we move on. It's not that we forget, but, we try to move on and be functional. So one of the things that concerns in perinatal loss is developing complicated grief. Now, who are the individuals? Who should we look for? Let's say not everybody kind of, comes back to us as seeking support or treatment. I think it's very important to identify women who are likely to develop complicated grief reactions so that is there any way we can prevent a pathological or complicated grief? So for that, we need to understand what are the things that actually contribute to complicated grief. One is the intensity of grief. The severe the intensity, the more likely that the person is likely to have a complicated grief. Poor marital relationship, poor social support, personality factors. Of course, personality factors, I'm not talking in terms of individual personality disorders, but more prone for neuroticism or poor coping mechanisms, previous history, because then there is a recurrent loss. So they are at high risk for complicated grief. Women who have had comorbid depression, they are more likely to have, complicated grief, anxiety, comorbid anxiety, and PTSD. So even though I gave you a list of things, many of them co-occur. And it's very important for us to do a proper assessment. So what is the impact of one, I talked about mental health consequences. The other impact is on the intimate relationship, because when there is a loss, both the mother and father grieve together but differently. So there can be communication. So the mother would want to talk about the loss, but father does not want to talk about the loss because the father experiences grief in different way. So that can put a lot of strain on the parental relationship as well. So it's very important for us to understand this. And that is why it is not just important to just address only the mothers, but also the fathers, because that can have an impact on the relationship. So you can imagine that the first is they have to deal with the loss, and then the subsequent problems that come up with in terms of problems with relationship and planning futures together. So all this can be, and it is known that many, at least in the research says that the relationship quality actually declines and then picks up after a few years. So, but a lot can happen during that period, isn't it? So, and many a times this also puts, if they were already having difficulties, this just adds on to their burden. Now, coming to this, so we were actually looking at, what are the practices that happen in our culture or country in terms of when there is a stillbirth, neonatal death. So few of the challenges that we've seen is, at least from my clinical practices, if there is a death, especially stillbirth, or the baby is not shown to the mother, or the news might not be disclosed to the mother, but family members know. So they kind of, there is some sort of a collusion that happens. And then the mother might get to know after some time when they would have cremated, or, there's no baby evidence that the baby has passed away. So that is that can be, I know that it's done with a lot of good intention, that the mother is kind of, just given birth and she's physically vulnerable and emotionally vulnerable. So let's not disclose this. So, and then they get to know after some time. So the mother is complete, it's like complete void. Neither has a image of how the baby looked, whether it was a boy or a girl. And they have all these questions. And they cannot ask these questions because everybody wants them to forget this and move on. And if you start talking about it, and then, it just leads to stress. And many of the postpartum rituals are not done because there's no baby. And the third thing is I'll tell you, it's like, they would have gone through so much of pain of delivery, parturition, and then there will be milk. Sometimes there's a milk production. So all these treatments have to be discussed with them. Somebody has to be very sensitive. So the body also is going through so many changes, and then there's no baby. So I think it's the process that actually, that's what I was saying. One is the loss itself can be a very significant event, but what happens after that is an additional burden and additional trauma to mothers. This is when I'm just talking about, let's say, stillbirth, neonatal death. Again, they are in the ICU, uh, and sometimes, how the mothers are given the message about the baby's health condition, and what they, it may not be also just the message, but it's also what the mother perceived and how they respond to it. So they may not have spent enough time in the neonatal ICU. They might just go to see the baby, feed the baby, and then, if there is so uh, it's different stages. And in uh, let's say miscarriage, many a times, I mean, the concept remains are not shown to the mother, because it can, of course, they don't want to see it. And so this is the challenge of, perinatal loss, because they have, it's there is no image of what it could have been. It, and probably whatever the image is there is of a mental representation that they would have formed at different phases of pregnancy. Like we all know, many a times people ask questions that if a woman, what stage, gestational age, if there is a loss, does that matter in terms of how the grief manifests? Like, for example, somebody losing at 3 months, 6 months, the findings are very quite discordant and quite, we expect that when the mom starts feeling quickening is there, when the mother feels the movements, or they have seen the baby image in the scan, we expect more attachment, and more severe the loss is likely to be. But research does not actually show that. Gestational age is not a great predictor of whether the woman will develop perinatal grief or not. So it's an indication that it's more to do with how the mother has conceived this whole idea of pregnancy and motherhood, and based on that, the grief reaction is likely to. Second thing is, does the maternal age matter? Maternal age, young mothers, are they more likely to experience? But no, it is actually, again, age does not matter. Is it the primary or multi? Not really. But what is likely, if living children are already there and then there is a perinatal loss, it can kind of work as a protective factor for developing, into complicated. And does, like, being married, of course, poor marital relationships, we know that it is a risk factor for developing psychological problems. So this is about how, the whole process of grief, and what are the other factors that can lead to complicated grief reactions manifest. And I'm just kind of going to take you through some of the assessments. Like a usual grief symptom, when we talk about it, we talk about, visual images, hearing someone talk, or hearing somebody, cry, or their toys, or even let's say older children, there are toys and things like that. But in perinatal grief, it's a lot about images that they have formed, or feelings and thoughts. So sometimes it's good. I find it's actually sometimes good to use these assessment tools. I put some of them. I think the perinatal grief scale is the most commonly used scale, which talks about three domains are there: active grief, difficulty, coping, and despair. So the symptoms are very specific to both in terms of burning, pining. So it was, earlier scale was some 100 items, but now it's a brief version, 33. There is bereavement scale, it's about 18 items, and grief intensity scale. Like I was mentioning, grief intensity scale is probably has uh, more of woman's expectations of how she should feel about the loss. and how families react to her reaction. So if there is a significant incongruence, what she is supposed to feel, but what she feels, then there is a likelihood that there could be perinatal, chances of complicated grief. So these are some of the tools that have been used in studies. Cultural adaptation of these tools are not done. The other thing that, when we look at literature, what kind of support mothers get, because I'm just talking about in and around the event. I've not gone to other, so is something called bereavement support. Now, bereavement support is basically that happens immediately, that support that is provided to the families. Most often it is the OBG team and nurses and midwives who provide this support in terms of one is breaking bad news and handling the emotional reactions and assessing, answering questions. So some of the strategies that, at least in neonatal death or stillbirth in the other way, some setups like US or UK, most of the literature is from France and other places, is meaning making. So where they actually take pictures of the baby's, and they have a proper funeral for the baby. They take handprints of the baby, and then they give it us. So that is something that's a very, they felt that whether these kind of interventions, whether they help the mother not to develop complicated grief. But interestingly, I think some studies have said that this actually kind of, reduced the psychological distress and trauma among mothers. But the reverse is also true, that in some mothers, actually the more they saw the baby, the more time they held the baby, the more time they spent with the baby, they had higher rates of trauma, right? So this becomes a tricky situation, because we simply sometimes adapt some of the interventions to our setup. Here, I know that many a times in certain religions, women don't go to the funerals, and the rituals are all done, or the family will refuse to show the baby to the mother, and that can be both vice versa. It can be traumatic, or it can be better for the mother. So who may, and it's also a tricky situation, because the mother is physically vulnerable, and then somebody has to make that conversation with the mother. And that is where, it is so important that we talk about these aspects to all the health professionals who are involved in the care of mothers. So, yeah. Should we take a break here?
Sure, ma'am, we can ask and take some questions right now.
I just have.
Yeah. So any questions till now? Anything that you would like to add on or you would like to ask?
There are some in the chat.
So yeah, so the accessibility of these scales, so are they available online?
Yes, they're online. They're online. Most of them, yeah.
So I think like there were some questions in our email as well, and that is something that I also want to check that in terms of clinical interview, so when this grief thing comes up, according to you, how do we assess that? Do we go deeper into that, or we just keep in mind when we are planning an intervention for them?
I think one is, it should be a routine assessment, and with the sensitivity to kind of, handle, if the, let's say the mother's readiness to discuss about. A good clinical interview is probably very useful, because you have a chance to kind of, interact and address the emotions as well. So I think allowing the mothers to talk about the event itself, when you clinical exam, sometimes just allowing them to talk itself is quite helpful. So talking to the mothers about the event and the feelings associated with it.
Right.
And at the same time, we should also be cognizant of the fact that if the mother has not felt sad or, might have felt relieved because there was a serious condition with the baby, we should be sensitive enough to not say that, okay, you did not go through this. I think our this one is to just as open-ended as possible, and checking the comfort is very, very
Right. So couple has a question that any kind of impact does loss impact differently on fathers? Like, are there any studies which show that how fathers are impacted with the loss?
Yeah, I mean, I think fathers experience a lesser intense grief reaction, but this is just the many of these studies are very, very small sample size. So we have to think, like, for example, we were looking at one of the review actually looked at 7 studies. Seven studies, out of which were 6 studies were only mothers. Only one study addressed the reaction to fathers. Uh, Fathers are slightly in the precarious position because they have to support they're also expected to support the spouse. So they're less likely to express, and they're more likely to grieve for a lesser period of time. But like I said, there is no universal way the men grieve. It also depends on their own mental health and coping abilities. But the data on fathers is very limited. It's unfortunate that the data on fathers, we've worked with, at least I know 2 fathers with whom we've worked on the loss. And one of the things that came up was that it's also delayed grief, because they were, it's like they were so busy with organizing the funeral and taking care of things, hospital admissions and discharges. And I mean, this is reality. So then I think, and the mother went off to her mom's place for the postpartum care. So the father was kind of, confused, and was feeling very anxious about, and was trying to make sense of what had happened. So I think sometimes, it's very important that we address father's loss as well.
Right. So just another question which was popping in my head, that when a mother or when a couple is going through an IVF process, they end up facing a lot of failures. So according to you, do you think that that kind of grief is similar to what we are talking when it comes to abortion or miscarriage?
Um, there can be similarities. There can be similarities. It's like, expecting a positive result, right?
Right.
Uh, and then it's not happening. So, but generally what is seen is it's the psychological distress which is more common rather than a loss.
Hmm.
Because, here you're somewhere in that point of time, your focus is more on being pregnant.
Right.
And once it is confirmed, then you start thinking and about, what pregnancy is and what is the fetus going to look at. So it might be even earlier stages.
Right.
Um, there are other questions. Should we take them now?
Yes, one is like one wanted to see the stages slide once again.
Okay.
And according to Lakshmi, she's asking, can we say that bonding between father and baby happens more after baby is born as compared to mother who feels a baby physically?
I mean, it's more theoretically, this is what probably is. But we know that now, with fathers watching the videos or the babies in the, I mean, due to ultrasound, and now the scans are of such good quality. So they can actually see, and they are very participative in feeling the movements of the baby. So I would not assume that, but this is more likely rather than, they having. I definitely, we cannot compare it is similar to what mothers experience and fathers experience.
Right. And the last question, Raksha wanted to know that are there any studies that show how the grief reaction manifested with previous generations versus now? Any protective factors in the previous generations?
A very interesting question, Raksha. But the thing is, this concept of perinatal loss and grief has started since 1970. So I'm not sure which I consider that as previous generation, because by 80s already scans were available. Few things could be different. One, if let's say the mother has a loss at home, uh, that goes unaccounted for. So we don't know how things happen over there. Now we know that many are hospital deliveries, so we have probably more awareness about what experiences are. So other than that, I don't know if there were protective factors. I mean, whether, like I was saying, number of children, they had more children, whether that's protected. No, actually, that even research wise, more number of children not necessarily is equal to not developing pathological grief. So it's multiple factors. So if I have to put it, it is individual factors, event related factors, and post event related factors that determine the mental health consequences.
Right. Sorry, one more question. What are some things to consider if couples therapy may be indicated versus individual work for only the mother?
I think couple interventions actually have been done for perinatal bereavement. So I am not very sure whether, I would probably look at, let's say, if the mother has both grief and depression, anxiety, already the couple have some, relationship issues. If the mother is quite not, very anxious, I would probably see the mother first, and then hierarchically I would put these. Like when we see that the mother goes through perinatal grief, we want to actually assess both couples individually, and then see if there are similarities that can be addressed as a couple. Like, for example, even if there are, like, let's say, unhelpful responses from the spouse, or then we want to address it in individually rather than bringing them together at the same time. So it's a very, very individualized treatment plan. So I don't think I can say that these are the indications for couples therapy.
Right. Thank you so much, ma'am. Like, we can move towards the second part of the presentation.
Okay. Now, okay. Not able to move. Yeah. I've just put, you know, all these forms of therapy. I mean, I have read what these therapies are, what is the interventions and what do these entail. One thing I have learned as a clinician and after going through all this is one form of therapy may not, yeah, or one school of therapy is a very narrow way of addressing grief. I think we need to use different elements of various therapies to address grief. First,
Hello. I'm so sorry.
uh, should I continue?
Yeah. Sorry.
Okay. So I will begin from bereavement counseling and support. Bereavement counseling and support, right now, I think in India, there is no formalized way of providing bereavement. This is the first level of support and counseling that happens immediately after the event. Now, what does this entail is one is breaking the bad news, supporting the emotional reactions, and like I was saying, asking questions about what their support systems are and how do we, what they want to do in with the baby who's passed away. These are the immediate things that, and these have to be done very sensitive, understanding their cultural ways of grieving. or after this, and many a times I think this is an important element. So if we provide this, and many sometimes parents will have a lot of questions about why it happened, the mothers will have questions about why it happened. There might be a lot of blame from the family towards the mother. I've seen this happening because I think culturally also in our system, the husband's family and the mother's family, they will have discussion on where the delivery, which hospital, which doctor. So in the event of anything like this, there can be a significant conflict that can arise within the family, and sometimes the anger gets directed towards the health professionals. So I think it's very important that this kind of care should be provided where the delivery happens or where the physician, whoever is looking after. So the guidelines which say is that, I think the person who, the head of the team should actually speak to the parents and answer the questions as honestly as possible, and do everything to support the parents in terms of whatever they would like to do. Many times the families don't want to take the stillborn baby home, and they would want to give it to the hospitals for, and then there can be sometimes they may want to do an autopsy if there is any suspicion. So these are all the things that are likely to come up in the aftermath of bereavement. So, and in our systems, there are different cadres of health professionals who cater to this. So it's very important that, how this is addressed in the most non-judgmental and respectful way. Studies have looked at whether if you provide good bereavement aftercare, after bereavement care, will it prevent from mothers and fathers developing psychological problems? The verdict is divided. Some say that it is it is helpful. Some men that it may not be very helpful. One of the things that I mean, somewhere I do also don't want to give this message that if you do it, it will all be all hunky. No, it is not like that. Sometimes inappropriate things are also done in during the bereavement counseling. So it's very important to be understand. And many of you are already trained health professionals. So when you train someone, what are the things that you should say and what are the things you should never say? Like, for example, I remember a lady whose baby had a very serious heart condition, tetralogy of Fallot, and multiple other things. So she had to undergo termination at fifth month. So the first thing I think that was told to her, good, you don't have to, carry on with the baby, which will have a defect. The so-called the word defect was used. You don't have to worry. It should be a relief for you. But the mother did not feel that way. Mother felt because there was a lot of messages that were given saying that some corrective surgery can happen and blah blah whatever. So the mother felt very guilty about it. So how what we say, how what we do are very important things. That's why I said it's not just about the event itself. It post event what happens and how, and then there can be one of the common things that they get blamed for is. What if mothers, especially from rural areas, when the mothers are referred late or they reach the hospital late and then something like this happens, so the first thing is very defensive, saying that you came late and that's why it happened. The third thing is not having services for mothers with high risk pregnancies, not getting enough services, or sometimes it's especially during COVID, it was very very hard. So some of these things all determine how we, their responses also are. So bereavement counseling and support, I think it is an important intervention, at least to not do further damage than what has happened. But how it should be done, and proper training is very, very crucial for, like, for example, uh, what will the nurses do? What will the obstetricians do? And everybody should be on the same page so that the mother is given. And many a times the why questions are very difficult to answer. I remember a lady who had lost a baby at I think 2 weeks prior to delivery date. It was, stillbirth. And they just could not understand why it had happened. But when they offered her, autopsy, she was very angry with the whole system. And so, because she was not able to kind of find the answer for why it happened, and that kind of kept coming back to her again and again. And at home they were all saying, no, you plan another pregnancy and then this is a closed chapter, so let's not think about it. So that kind of, there's a lot of mixed feelings that were left. And the family were understanding what the health professionals were telling, but she was very angry, and the family wanted her to go back to the same obstetrician. So that was kind of becoming very, very complicated. And so bereavement counseling and support is something that has been probably used in different countries. I think in some time, I'm hoping that there will be general guidelines that will be available for bereavement support, bereavement aftercare. Because this is also an opportunity for us to actually look at women who are at high risk for developing serious mental health problems. And how do we provide support, and how do we be cognizant of that? Because many a times once they are discharged from the hospital, they don't go back to the obstetrician, it's other than one checkup. So uh, there's no way of keeping in touch with them. And if they have a baby, at least they're more likely to come to pediatrician and other places. Even then, postpartum mental health care is a challenge. So I think it's very important that this gives us an opportunity for at least taking care of women who are at risk for developing. And always checking for safety of the mother is something that is very, very important. Now, coming to grief resolution therapy. So, grief resolution therapy, I mean, reliving, revisiting, and reconciliation, or what is it? I'm sorry, I forgot the last R. So, but that's your classical grief resolution therapy. What is seen here is somehow I mentioned, reliving, revisiting is a bit of a challenge here, especially if the mother is, I mean, like how we do with, other losses. It's in early stages of pregnancy, it's revisiting and reliving can be quite challenging. But like I said, it's not just about the concrete things, but it's also about the what representations and what thoughts and hopes and dreams that the mother had that, that have been taken away because of this loss. That's very important. So when to use grief resolution therapy is something that you need to take a call if you feel that the intensity of grief is quite severe, but there are no other, comorbidities like depression, anxiety, and PTSD. Then probably grief resolution therapy can be used, where you know that it's just the grief symptoms that are kind of coming in the way. Uh, Second would be, I'm not going into the principles of how it is done and what, because it's quite vast. Supportive psychotherapy. I'm looking at all these elements as, you need to individualize treatment. So please do not try and do something, because like I said, many of them, they inappropriate treatments can actually make their condition worse. Supportive psychotherapy, especially with women who are going through multiple issues, perinatal loss, difficult, relationship, not having enough support, I think to begin with, you could start with the principles of supportive psychotherapy. A good, clinical interview, communication, listening, validation, allowing the person to talk about their feelings. I think that's very, very useful once you feel that there are certain things you've heard, and then you can move on to other forms of therapy. Coming to CBT, cognitive behavior therapy, where can we use? So again, cognitive behavior therapy, I think it's the most used treatment across all mental health conditions. So one of the things that is probably where there is an element of trauma, psychological trauma that has happened as a part of, loss, you could use CBT. And of course, there is evidence for CBT in complicated grief following perinatal loss. But you have to understand that these are treatments that it is an internet-based delivery. Again, the research evidence is not very robust. Then there is interpersonal therapy. You know that out of all the 4 elements that we talk in interpersonal therapy um, uh, is grief and loss, right? So where you address this, and this is in fact, IPT also uses some of the principles of grief resolution therapy. That means basically the strategies that you will use, I sure if I have it, and narrative therapy. So I'll just come to some of these at least. I think Anika had asked about when to use couples, when to use individuals and family therapy formats. At least in the Western, I would call Western. Western is a very broad term. At least there are studies where grandparents have been involved for grief, because for them also it's like, a loss, and grandparents have been involved along with the mother for grief therapy. So for IPT, let's, I mean, all of you know the principles of how interpersonal therapy works. So here, again, this has more evidence for stillbirth and neonatal death. So these are some of the strategies that are useful in IPT. Like, for example, the symptoms have to be connected with the loss. Then you kind of go over the relationship that the mother had formed with the baby or the fetus. Then talk about going through the events just before the loss and during the loss and after the death, because that is where you can actually kind of think of blame, gay feelings of guilt, how did they emerge? And then you can move on to consider ways of establishing new relationships. So it's this is very theoretical, but when you actually practically do it, it is basically when they discuss about all these feelings, how do they process anger, if there is anything that is related to health systems, or anger towards the family for not providing that kind of a health, not having the support. So when they express their feelings, they are able to kind of, process the whole event in a better way. And also kind of meaning making. It's one of the things of grief resolution therapy is IPT is also that, it could be the loss and how they make sense of the loss, meaning making, and how it's sometimes it's just about, forgetting. It's not about forgetting, but the family wants the mother to forget this loss and move on. But what you're trying to do is you're trying to make sense of what has happened, and how, having this memory, you still can get back to life and rebuild your life and carry on with new, a changed version of your life. So I'm just putting these things because I always feel, I know, I'm sure there are enough psychologists and who are great therapists here, but my idea, and from whatever I have worked with, I feel that it's, sometimes it's important to just understand the process and changing techniques based on what the process throws brings up in therapy. I think that's something very, very crucial, especially with grief. I think narrative therapy, I think some of you are all trained in narrative therapy, because I think this is probably, especially for someone who can write and who can, journal. I think narrative therapy is very, very a useful therapy that has been used in perinatal grief. Again, narrative therapy, it's also about two, three things that I just wanted to highlight in this is which kind of client will be, who can actually do narrative therapy is someone who can vocalize, someone who can verbally express, even if they're not verbally expressive, if they're able to write what they're feeling, thinking, I think that's a good thing. Narrative therapy, it's also, you can kind of pace it at this pacing is dependent, whatever therapy you do, pace it according to the mother's feelings, and not everybody can work at that 12 to 16 sessions or 6 weeks of session. And sometimes, even though we start with perinatal loss, it's actually not the loss per se, but something else that would have, been more important. So, I mean, some of you can share if you've done some narrative retelling. I do know, I do remember a mother who had written a very nice, uh, I think for her, it was about saying goodbye to the baby. Saying bye to the baby, saying that, she did everything possible, and it's still, did not. I mean, of course, she had a religion aspect to that, and then felt that the child was in a better place, and then how mom still misses, but is able to save her. So there are lots of different ways, and go by the client's abilities, and also about abilities to express as well. There is no one way of grieving that I keep bringing in again and again, because I have also seen mothers dropping out of therapy sessions because sometimes things were getting very intense, and that's where they put a stop. So it's irrespective of what therapy approach you use, please ensure that how the focus on the process. I think it's very, very important. I know, like I was giving you an example of the mother who lost a student. She's not willing to go back and talk about what happened at that point of time. Now, how do I move forward with this lady? She says, I don't want to talk about it. I am planning pregnancy now. And I want to kind of, because probably that was helping her to keep herself. So, but at the same time, but her angst was, her anxiety was, being shown. She was irritable, angry. So it's very important how we work with these different situations. That's why I keep saying process is very, very important, and working with the pace of the mother. Yeah, I mean, I think, I am not going into too much detail about what these therapies are. And so, and again, in our, there are people who write in different languages, and then they have their own ways of expressing. You could also use, I mean, and just put these just for discussion. Um, I will move on to, I think it's already time. So grief and father, somebody asked, and like I mentioned, it tends to be less intense and for shorter periods, often tend to internalize and deny, attempt to distract than speaking about their loss. So like I was mentioning, and if they're grieving differently, then you can't do couples therapy. So yeah, I think most of these things we've discussed in grief in fathers. General principles I will talk about. Allow the mother to speak about her loss. If the mother is not ready, give the space. And also give the privacy, and also discuss about confidentiality with the mother to speak about her loss. Validate whatever feelings the person has. Sometimes it's also health professionals. As health professionals, we also become a little defensive about our systems. but then, it is what it is. Um, Explore the impact of grief over her current life and support systems. I think sometimes it's important, like I was talking to you about supportive psychotherapy. One of the goals of supportive psychotherapy is about, getting back to routine and at least starting something for herself so that, she's able to manage. And also, if there are living children, please ask about the impact of grief on how she's caring as for the living children. Okay, this side. So I've just kind of put some this one. I think first and foremost is if you're a therapist or a clinician, ask about reactions to loss. Explore, and many times I think we just, we when we are doing evaluations, we just say, okay, abortion in the past. That's what is written. But I think reactions to that event, it's very important because it will also predict the mother's mental health for the subsequent pregnancy. So it's very important that we ask. Culturally sensitive post-bereavement care is very, very crucial, at least in our country where the rates of stillbirth and neonatal deaths are still continue to be high. And I think it's very important to kind of identify high-risk groups and provide intervention. And at the same time, culturally sensitive interventions are very important because we know that there are different practices for grieving. So, but at the same time, I also strongly believe that grief is a universal phenomena. Loss is a universal phenomena, and the emotions are universal. It may be the expression and experience of emotions that are different. So it's very important for us to be aware of this. Okay, I think I'll stop here. But if you have any, I did rush through some of the interventions because I thought we were running, which is 3:15.
Yeah. Thank you, Dr. Geetha. So we have a couple of questions in our chat box. So Madhu is asking us if is there any intensity difference in the grief and the self-blame or blame from family, the losses of a male child, considering we are largely patriarchal society?
If you ask me as a researcher, there is no evidence. Again, it depends on whether the first baby or the second baby. But otherwise, gender of the baby actually does not really, hasn't shown that intensity of grief. But you might be right when there is a, there's a stress and need, but they need not develop only complicated grief, but they can develop depressive episode as well.
Right. Thank you. So, and Raksha is asking that in your experience with our cultural context, how can the why question be navigated largely? Also, any practical interventions or meaning making in a cultural setting that has been tried and tested?
Yeah, I mean, I think why question has no answer. Why is something, I think when people ask, why did this, I mean, we all ask ourselves, why did this happen to me? I mean, I think it's a very normal question, and I think we should answer the why question. We should validate that, you are having these questions. And many a times, why questions are more about the loss. If about the health system or what happened to the baby, then it's a different matter. Why did this happen to this loss happen to me is a different way of asking this question. So in our culture, it's also about, karma and, maybe I did not follow certain rituals and that's the reason why I was facing it. So I think exploring it is important. What do you think, is why did this happen to me? So can we explore about it? What all have you thought about it? And it's never, we are never going to get the answer. I mean, at least 100%, even if there has been a loss due to let's say some mother had preeclampsia and the baby passed away. So you can actually say, okay, this many of the mothers lose the baby because you had preeclampsia, and yeah. So they can, if a mother is vulnerable, actually she can start thinking of, maybe I should have been more careful. I should have had more checkups, antenatal checkups. We know that mothers who have gone through perinatal loss, they actually become more and more aware of, and they want a more care during their subsequent pregnancies. So I think it's very important. Now, meaning making in our cultural setting hasn't been tried or tested. And it also depends on the socioeconomic status, where they deliver, how uh, or how the system has addressed it. Very, very less literature. Uh, One, I think, like I was saying, there are mothers who have not seen the baby post stillbirth. So, and it is a very tricky thing. So, because you can't ask the mothers to be prepared for something like this, like how we have, advanced directive. No, we can't. It's not possible. At least, how do you talk to your mother like that? But you can actually. My only thing is, can we at least have that conversation? And the families will come in the way when you start actually asking the mother, would you like to see the baby? Would you like to hold the baby? And we should also not go with the notion that that is the right thing to do. Let's also, there are studies which have actually looked at the distress the mothers went through when they held the baby which had passed away. They were more distressed, more traumatized. So it's I think we need to have more research in our population to actually use this strategy.
Right. Thank you. So I'll be taking some of the questions that we received through email. And one of the questions is, I think a lot of
Shall I stop
therapists,
sharing?
sorry, yes. So I think that's a common thing that a lot of us as clinicians struggle with, like especially when it's grief. Like as a clinician, apart from validation, anything to be kept in mind when we have to interact with the client, what to say to them when they are, talking about their grief, because nothing seems okay.
I think one is not, if we don't know the circumstances of how it happened, I think we should not answer these questions. So many a times they'll ask us whether, do you think I should have gone to the other hospital? Was there a delay? They come to us because, more so in psychiatric population, because they would have used the medication. Do you think I used the medication because of which this happened? Should I not have taken the medication? So I think it's very important to be honest and, tell them. And also, when I say validation, it's also about being with them. It's very important to be with them in that grief situation. I think, otherwise, as health professionals, we can be very, it's your emotion, it's your this. And I think the sense of giving that being with them in this grieving process is very, very important. And that happens is actually if you can, let them express. And at the same time, we all know grief is it's a reaction that happens, and we need to just active listening is something which is very, very crucial. And not say things or not discuss things about which we also don't have answers.
Right. Thank you. So there are a lot of questions regarding abortion. So a couple of questions are like related to physical and emotional impacts of abortion and any long-term impacts psychologically.
I think recent systematic review did not really reveal post-abortion high rates of mental health consequences, but recurrent abortions and the circumstances around abortions, it's like assault or unwanted, and multiple other ongoing problems may contribute to mental health condition. But it's not necessarily that, So I'll take this question a little more, because we have to be very, very careful. If we say that mental health consequences of abortion are very, very high, then that can be an issue. So we need to look at it objectively. So that is where this evidence is important for us to say, let's say if a woman undergoes termination or has an abortion, does it increase her risk of developing depression, anxiety, and then, it's actually not, at least the recent meta-analysis did not really show an increased rates of mental health disorders. But like I said, if the mother, it's a good preclinical practice to ask about how the reactions were and differentiate whether they had a depressive episode or just a grief reaction.
Right. And do you think a mandatory counseling before abortion will help in combating these impacts?
Yeah, I I have also looked at a literature on pro and anti abortions, and where mandatory counseling was not okay. The woman is going through abortion, and then you show her the videos and show her the heartbeat. So what do we mean by counseling is something we need to think of, right? So, but screening, let's say if there is an elective termination, discuss about, instead of saying mandatory counseling, I would say talk about support systems, talk about possible reactions, talk about if they have had any mental health and how we can support them even after this process. So that's where I feel this area we need lot more evidence based ideas and interventions and assessments.
Right. So there's a question where you've been asked, what kind of treatment mode will help? Like in terms of, do you think online therapy or therapy over the phone would be helpful? And what about complementary and alternative medicine in these cases?
I think there is evidence for internet-based cognitive behavior therapy and IPT. At least, like I said, it depends on the clients and the severity of grief. Yeah, and where let's say there is a risk of self-harm, then how do you do this? So I think I don't have research-backed evidence, at least from the Indian scenario, about what works better. But at least in the West, there are studies which have looked at internet-based and face-to-face. This was almost the same.
Right. And how far is perinatal loss compounded by hormonal factors triggered by an abortion?
Those are applicable across all postpartum period and pregnancy period. We do know that progesterone, how estrogen and progesterone, but the drop is not as significant as it is after childbirth. But they could. There are no measurements that have happened post-abortion looking at the hormonal profile.
Right. So, and in grief, mostly there are a lot of clients who come with a freeze response and they don't want to talk about it and they just sit in silence. So, what are your thoughts about it? Like to just sit with them in the silence or approach them to talk?
I think give them the space. Sometimes, pushing them too hard might not be a great idea. Sometimes it's also about, and they might want to talk about other things. So using not a direct approach, but if they would like to talk about anything else, that's fine.
Right.
It takes a couple of sessions if they are, in that freeze kind of a situation. Sometimes it's also about not breaking down, not sure whether they're ready to experience the pain. So if we create a safe space for them, they probably, and it might take a couple of more sessions also. It's fine.
Right. And do you think the history of a perinatal loss has some association with pseudopsychosis as a delusional disorder?
I'm not sure.
Right.
I'm not sure.
All right. And we have received a lot of, I think, questions regarding psychotropics and medication, which is not in purview of our today's talk. So I guess like if and when we have another topics going on, so we can discuss that in detail. Then Raksha has another question, that any active support groups we could direct our clients to address perinatal grief.
Not right now, not anything that I'm aware of in the current scenario, but I can look up. There are in Australia, there are UK, there's a support group, and Canada, there is a online support group. But at least in India, I'm not sure.
Right. Any other questions from the group that you would like to discuss, or any case examples that you are struggling with? So meanwhile, the audience is thinking about it. So I just want to bring up, I think, one of my recent struggle where, again, I don't know where to put it, that one of my client got pregnant with twins through IVF process, and in the process ended up losing one child, and the other child was alive. So she was in dilemma, like either to process the grief or not process the grief, either to, like, even while delivery, either to see the dead fetus or not. So there was a lot of dilemma. So any thoughts about that? Any thoughts about how it could have been managed better?
Um, I think this happened immediately after the loss,
No, no,
isn't
no,
it?
no, no. During it was in the starting of the third trimester, there was a loss, and then, but they couldn't take the fetus out because the other baby was alive.
Yeah. Um, I think we should not stop her from, expressing the grief, because, expressing the grief might be crying, or, how do I feel? So there may be a lot of confused feelings about it. Her fear could be that, if I grieve, will something happen to the other baby? I think it's very important to address that. The second thing is, you know, what could happen if she sees the fetus? What are her concerns that if she sees, what will happen to her? I think sometimes, they might feel that, okay, I might break down, or I might, not be able to. So then we can actually discuss. So what are the things that can be done even if she breaks down, and how things can happen?
Right.
What will happen if she does not see?
Mm.
Because some of these questions are more scary when they're in our head, but then when you actually discuss the fears out, then we can find solutions for the same.
Right. Thank you, Devanshi.
Yeah, I was also just sitting with the immense amount of complexities that revolve around grief. Especially, I think that stood out for me was how you've not at all seen, and what do you hold on to? Something that I was thinking also about is post the grief, the woman is always bombarded with, opportunities, expectations that you try again, it'll work out, and where I'm wondering what would be the markers for the woman to be able to know within herself that I am truly ready to try again. Removing the voices of the society, of the family, and all those aspects. What are there any parameters through which probably she could know?
One thing is about the frequency of thoughts of thinking about the baby, the miscarriage or whatever, as how much of emotions, thoughts, and feelings are spent in understanding
Mm.
that. The other thing is always asking about what would be her concerns for the pregnancy. Will, if
Right.
she's anxious, what is likely to happen? I, I don't think 100% readiness is ever possible, because some degree of anxiety is likely to be there, but it's more of preparedness, better care, better ways of monitoring. So this is a very thin line. They should also not go overboard, like getting multiple scans and constantly checking for the fetal viability and things like that. So it's a balance that they need to, talk about. Readiness is something that mother, whether does she look forward? Does she get positive thoughts about the conceiving again? And are there any positive thoughts? And many a times I think this pressure is so much from others that it no longer is about others. They internalize it so much that it becomes their need rather than, and also having a very realistic ideas about, they feel, many a times they feel that they will forget everything that has happened because there is a baby now. And I think that's quite unrealistic. So it is like, okay, it is there somewhere and it might come up at different. It's like, grief resolution does not mean that the memories go away. Memories are there and they are likely to creep up, but you're able to kind of manage and address it and manage it. So I think that's something that.
Yeah. Sorry, I had another question and more of a recent scenario that happened. I think apparently UK is now giving certificates, like the government certificates, to women who have lost their kids or, through perinatal loss. And I remember you mentioning about it being a double-edged sword in terms of if that is really helpful. I was just wondering if you could further elaborate on the positives as well as the negatives.
I mean, it's like a reminder for loss. You can use it for a reminder for loss. Constantly, you can look at the certificate and, that, or it could be associated with the fact that I had a baby, which is a positive association, or it could go either ways. Now, what is the purpose of having that certificate? I am not very sure. What is the purpose of giving someone saying that it's like, is it like a death certificate?
Yeah.
Right? So, I mean, there are reasons why we need to have a death certificate for adults or other individuals, but it is important to know the cause and other things. But I think it depends on the individual. So if you're traumatized by this event, the certificate can actually kind of backfire. It's a constant reminder for the person that, something like this is.
Thank you.
Any other questions from the audience? I think if we don't have any questions, we are good to wrap up. So on behalf of the Green Oak Initiative, Dr. Geetha, I would really like to thank you to enlighten us with this less talked topic and a very relevant topic, which we see in our therapeutic work on a very regular basis. Thank you so much for enlightening us with it. And it was a great, enriching and informative conversation. Thank you so much.
Thank you. Thank you.
Thank you so much.